some of you have attended the trainings for competency-based education in UG level, at UG level. Now, what is the difference that is there between the UG level? ನೀವು ಹಿಂದೆ ಹೋಗ್ಬಿಡಿ, ಪೂರ್ತಿ ಹಿಂದೆ ಹೋಗಿ. Now, what is the difference that is there between the curriculum of UG and PG? Both have competency, but the level of competency for UG and PG are different. In fact, if you recall, there was a kind of mention that Dr. Jatkar made, EPA. And he also said that Homoeopathic Commission is the only commission, or the first commission in the country, which has brought in this EPA-based curriculum in any professional course in India. Now, the PG curriculum is a little beyond the mere competency and goes into entrustable professional activities. The EPA expansion is entrustable professional activities. Now, there are two words which are very important in this. Activity is something which is common. Entrustable, professional. It is the professional activities that you expect your postgraduates to perform after completing this, and what is more important is that you have the trust that they can perform it. Now, how do you trust? Trust is something which is very, very, very important. And that is what we are going to explore. What is the background for this trust? How does this trust develop in you? And how do you trust your students to perform in the real life situations, whatever they have learned in your course? That is what is this EPA about. Let me give an example before we start this. Imagine you have bought a very high-end car for your child, son or daughter. New car. And this child still doesn't know how to drive. Will you give that car to that child? Oh, okay, go and drive now? No. What you will do? You will put that child for training, driving under some coach. You may coach how to drive. Then after and it is not in that car, it is in some other car. Right? Then once the child becomes somewhat competent, the word competent comes here. Once the child becomes competent, you feel the trust. I can give this new car to him or her, and before you let him go independently, you'll sit behind, check how he or she is driving in various traffic situations, and then when you are satisfied fully, in future this person will use this with safety, and you have the trust. That is when you give the car keys and say, okay, go now. That is what is the car key you are going to give your postgraduates with the full trust that they will not mess up with the patients when they start practicing in the future. In that background, you have the trust that this person can make happen. When you look at this image, I'll show one more contrasting image. Which wall do you trust for your house? The first or second? Naturally, because for various reasons. Now, how does this trust develop? If you transplant this wall into a person, into your post-graduation, how do you trust that person to be entrustable? Entrustment. Entrustment comes from various dimensions. When you trust somebody, at the core is that the person has sufficient knowledge and skills for performing that. Now you have your postgraduate, and that postgraduate is now becoming an independent doctor. He or she sits in their clinic, in the hospital, in the community. You trust because they have sufficient knowledge and skills. The second component, the rest of the components are nothing to do with the knowledge. They are to do with the person and the context and the performance. One is they have the discernment to use this knowledge to the best of their ability, in the best of the context. Like they will not misuse. Discernment is the wisdom that they can discern, I should do this or I should not do this. The person may be skilled, that may be necessary, but you may not allow or you may not perform certain things under certain constraining reasons for which you need to have the wisdom. So discernment. The third is truthfulness. Is this person truthful? Now, why do you want this truthfulness? Because not everybody is perfect. Everybody is liable to commit some mistake. And when somebody has committed a mistake, will that person honestly come forward and say, this was a mistake I committed? Let somebody help me out. Vulnerability is the most important human character for developing entrustment. And vulnerability is expressed only when the person is truthful. So truthful, is this person truthful? And the last one here, conscientiousness. Does the person have the conscientiousness to use the ethics, the morality, and whatever else to the best of the situation there and for the best of the person whom he or she is treating? So these are the qualities which we observe over a period of time, but most importantly, we need to predict this is how this person will continue to do. He or she might be doing it for some time. When we observe, integrity is something that a person does when nobody is observing. So does this person have the integrity? You can only predict. You cannot have the previous experience and to say, okay, this will happen. So that is what is entrustment. With this background of the concept that what you need to develop is entrustment, the capacity to be trusted in your students for post-graduation. Let us go further into the introduction to the competency-based curriculum implementation at PG level. Now this session is in 3 components. One is the concept of entrustment. Second is the structure of this curriculum. And third is preparing for implementation. The second component I will not be delving too much because that is what will happen in the post-lunch session by the various subject experts. The first and third is what I will be more concerned with. So by the end of the first session, okay, now to say that learner is the focus of all educational activity. There's one more kind of interaction here with you, a mental interaction. All of us agree that learner is the focus of all educational activity. To ensure that learner is the focus of education activity, there are 2 models of teaching that we have. One is a model of teaching that you have here, where you force feed the student with all the knowledge, skill, whatever that we have. And the second model we have is the one where the person is facilitating a student or a ward to be able to perform certain thing. Of these 2, for entrustment or competency building, or to make the learner as the focus of all educational activity, which would be the more ideal model, the first or second? First or second? I didn't hear anything. Second. Thank you. It is the second model that we need to be focusing on, and this is what is a core concept, or you could say the foundation of our mindset. We need to develop a mindset to empower somebody, and to empower somebody, you need to give up your authority, not responsibility. You need to give up your authority. You need to give up your ego. You need to give up the feeling that I know everything and that control. Only when you lose that, only when you have the mindset to give up that, to sacrifice it, only then you can develop entrustment in your students. If I'm holding this and not letting this go, this will not function. This will stay where it is, where I am holding it. So if you want this person to see somewhere else, you have to let it go. And that is what is learner is the focus of all educational activity. To make learner as the focus of all educational activity, in the concept of entrustment, this mini session, not exactly mini session, it will take some more time. By the end of this session, you should be able to trace the evolution of competency as a theme in healthcare education, discuss the theoretical foundations for competency-based medical education, clarify the domains of competencies for homeopathic practice, this is very important, and finally, explain the relevance of entrustable professional activities in health professionals education, or you could say homeopathic professional education. So these are the objectives that I have listed for this session. Let us come back and see how much we have learned on this. What is competency? Competency is defined as a habitual and judicious use. You can see there are two words which are very important. It is a habit. It is not something that I do today and not do tomorrow. And maybe do today and tomorrow, not do day after tomorrow. It is something of a habit. I keep doing the same thing every time I do that particular activity. So it's a habit. And it is judicious. That is what we earlier saw, discernment. Discernment is wisdom or judiciousness. So it is a habitual and judicious use of a range of competencies. You have communication, knowledge, technical skills, clinical reasoning, emotions, values, and reflection. All these at the same time happening when you are making a decision and when you are performing something in the daily practice for the benefit of the individuals and the communities that are being served. So it's not just the individual, it's also the communities. So whenever we are dealing with, it's not just for the postgraduates, it's also for us. It's not only in the clinical situation, it is also in the teaching situation. So the context of competency is in a wide range of real life situations where the person is said to be competent when he or she is performing judiciously and habitually a range of these activities in relation to whatever is the context that is being to be performed. Now, how does this competency set in? Before we go into the concept of competency or how this came into being, we have to trace a kind of inflection point in the history of medical education. Something which is very painful for homeopathy, but something which is a real thing. Around the year 1910, there was a report published on medical education, the nature of medical education in North America, the present US and Canada, by a person called Abraham Flexner, which was sponsored by Carnegie Foundation and under the aegis of the present day Johns Hopkins University. That report was so damning on the state of medical education that the entire medical education had a complete rehaul. And when they say rehaul, there were multiple nature of medical schools. There were mainstream medical schools which remained. There were homeopathic medical schools. There were herbal medical schools of American background. And interestingly, there were black medical schools. There were women medical schools. The reason is women and blacks were not allowed admission into the mainstream medical schools. So they had their own medical schools. So all these things, this person went around, Abraham Flexner, and then gave a report stating about the nature of training that was happening and made recommendations. Interestingly, the recommendation that he made was to have a 2+2 training module, 2 years of preclinical and 2 years of clinical training, exactly the one that we had for DHMS. We followed the person who had slaughtered homeopathy and used his model for our training till some time back. Anyway, that's another issue. So that is the point from where we trace the current medical education, the growth of, the evolution of current medical education. Beyond that, what happened? No, this was something like you have 2 years of preclinical, you teach anatomy, physiology, biochemistry, all these things, chemistry, physics, a lot of things were there. Then after 2 years, when they complete these things, you will send them to the clinics, you will send them to the hospitals and give the clinical training. Down the line, there were some thinkers, especially in Johns Hopkins, like two Williams, one William Osler and one William Halsted, one medical person, one surgical person, who have made immense contribution to the understanding of patient as the core of clinical learning. And that was taken up by one of the universities called Case Western Reserve University in the 1950s. They totally reshaped their medical curriculum to have an integrated approach. The approach that they had was, they will not have anatomy, physiology, biochemistry, all these things in first year, and then you go to pathology, and then you go to the clinical parts. What they said is, in the first semester, we'll have one system, say gastrointestinal system, where we'll be training the students in the anatomy, physiology, pathology, biochemistry, everything, including the patient management of that system, completely integrated. Then you go to the next semester, some other system, next semester, some other system. And this was the kind of foundation that enabled the appearance of competency-based education, starting with the US. So after the Case Western model, we had the World Health Organization, which had commissioned some scholars to do an in-depth study on how to bring about a kind of context-based medical practice. So the first article on competency-based medical education was published by WHO in 1978. Beyond that, we have some personalities, like we have George Muller, and we also have Ronald Harden, one in America, one in England, who have contributed for understanding and deconstructing the learning and assessment, so that it becomes clear how you are teaching and how you are mapping the teaching to learning. So if you look at the curriculum in BHMS, you would have seen something like Muller pyramid. It is this Muller. Sorry. So it is this Muller. And you have heard of something like ASCII. That ASCII was something which this person brought up. Right. Now beyond that, in the 21st century, we have the ACGME and CanMeds from US and Canada, who studied extensively and published documents on how the medical education has to improve. So we have the first publication of entrustable professional activities in 2015. After 9 years, we are discussing here entrustable professional activities in homeopathic domain. Medical domain, they are still grappling. National Medical Commission, Dental Commission, Pharmacy Commission, Nursing Commission, nobody has taken cognizance of this except some universities. Okay. Now with this history in the background, let us see what is this competency-based education in contrast to what is the traditional curriculum. In the traditional curriculum, you have the content, that these are the things which the students have to learn. Like you have the topics, and the topics are listed where the teaching happens, and then you have the assessment. You have the content, the teacher comes and teaches, then the examiner examines. This is like what we call transmission model. Transmission model is where you have something like a mobile tower, and that mobile tower is emitting signals, and you have your mobile. If your mobile is compatible, it will receive that signal. If it is not compatible, it will not receive. So whom do we blame? Do we blame the handset, or do we blame the tower? We have to blame the system. Right. So that was the model, transmission model. In the transmission model, I am as a teacher talking whatever I know, whatever I want to know, I want to tell, And the students are there, some are listening, some are not listening, some are getting it, some are not getting it. And finally what happens is, only 10% gets into them. Only 10% of what we talk formally in our classrooms, clinics, is retained with our learners. As against this, the competency-based has a different model where you consider what are the community health problems or the community health needs, national health needs. You make a list of that, and on that basis, you design what is that this person should be able to perform. What are the competencies this person has to acquire, and these competencies are first tested to check whether this person can really do this feasibility study. So after the feasibility study, when you are sure that this person or anybody can do it, it is doable, then you get into the teaching, and then you have the assessment. This is called as transformation model of curriculum. So transformation is, you transform the person, just transmit, don't transmit. You make the person to be competent. You make the person to be entrustable. So that is what is the transformation model, and that transformation model is the philosophy behind this competency-based curriculum. How did we develop this transformation model? Is it something that it came as a kind of intuition, or was it something like somebody's opinion? There were some studies which have happened, especially in the strategic studies, in the military studies. The person whom that you are seeing there is Dreyfus and another brother. They designed a model for training the fighter pilots for US Air Force, and that model is called as the competency-based model of learning. At the base of that is the person is a novice, doesn't know anything. That is what your undergraduate person, when they start the first year BHMS, would be. And after that, after training, a person becomes advanced beginner. I'm not getting into the details of these things. And then the advanced beginner with more learning and insights becomes competent. This is what your UG person is. The UG person is competent. Now beyond that, you have to differentiate what is the quality of a UG and what is the quality of the PG. And the quality of the PG is that he or she is proficient. Beyond competency, proficiency is when you can perform the same thing with less effort, with more economization. So proficient, and then beyond proficiency is expert. Please remember this background, because we are going to relate this in an actual situation of EPA a little later. Now I said competencies. What are these competencies? The competencies are what are the areas of performance. In fact, these are called domains of competencies in ACGME. If you look into CANMETS, these are called roles. Now roles will give a more clear idea of what it is. A person has to perform the role of having knowledge and scholarship. So one competency is this person, whomever you are entrusting now, has the knowledge and scholarship. Not just knowledge, also scholarship. The ability to learn and improve that knowledge. The second component of this is called as patient care. How do we apply this knowledge into the clinical conditions, patient care? And third, for homeopathy, it is homeopathic orientation. So whatever patient care you are doing, is it in consistence with the homeopathic principles? Then you have the communication skills, which is, as all of you know, quite important. Then you have practice-based learning. Now we say lifelong learning. How does lifelong learning happen? Lifelong learning happens as a kind of iterative process of what we see, what we observe, and what we reflect, and then this cycle. So that is what is practice-based learning. You learn, you improve your capacity on the basis of the practice that you are doing. And finally, professionalism, which is quite important for any profession. So these are the 6 areas that the NCH has approved are the domains of competencies. Now what is the importance of this? The importance of this is when you are planning your training, you have to plan specifically which area, I'll come to the EPA a little later, which area of that EPA, which component of that EPA is knowledge and skill, which is patient care, what is homeopathic orientation. Because when you are improving their performance, you have to give the feedback. When you say the student did not perform, suppose there is an EPA that the student is able to communicate the complications of a condition to the patient or to the attendants, has to communicate. Now, what are the areas the student has performed well, or what are the areas the student has not performed well, has to be clearly defined, because you need to give specific feedback. See, your knowledge was insufficient in this. Your communication was faulty on this. Your homeopathic orientation was lacking in this. When you say in the EPA, in each EPA, these are the dimensions of their performance, and these are the dimensions in which their performance has to improve. There has to be something which is very clear template. That clear template is this domains of competencies. These are the 6 areas in which you observe your students perform, and you give feedback for your student, and you see the improvement in those areas, so that you are able to trust them for the clinical practice. Now, when you look at the mapping of EPA, now you have the entrustable professional activity. We'll see more of that a little later. Suppose this is activity 1. In this, the knowledge and scholarship is very heavy, whereas the patient care is not that heavy. The homeopathic orientation is moderately heavy. Then communication skills are not that heavy. Then you have practice-based learning, which is not very significant, and professionalism also is not that significant. Take an example of potentization. For the potentization, the skill and knowledge have to be very heavy, because they need to have the basic understanding, knowledge, all these things. The patient care is not there because the student is learning how to potentize. There is no direct contact with the patient. Therefore, the communication skills are also not that very important. But the homeopathic orientation of that particular activity is moderately heavy. So like this, when you look at the EPA, for each of the EPA, what is the intensity of each of these domains of competency has to be clearly mapped. So once you see that, it becomes easier for you to train and assess and then entrust. Now, what is EPA? Entrustable professional activities. These are the units of professional performance. If you take the whole performance, there are multiple units. Like there is a wall, there are multiple bricks that form the wall. So these are the bricks which form the wall. The units of performance that capture the essential competencies. These units tell what is the competency this person has, the different areas of competencies come together before the trainees become proficient to undertake that particular activity independently. So when you see the EPA, there is an EPA, whatever the EPA is. So in that you track the student's performance and also predict how this person is going to perform basing on certain factors. And these EPAs are the units of any performance, not only for learning but also in their clinical performance. Now, what does this EPA do? This EPA is the task that can be given to the trainee to perform without supervision independently when they are able to, when you say that they are able to know that they are, I liberate them from my clutches and they are independent to perform. The second thing is, these are the areas, these are the templates for making the assessment and training. There are two things that EPS function. EPA functions by clearly stating what are the areas of performance, units of performance that I want this person to be entrusted with, and how do I conduct the assessment. There are 3 dimensions to that. One is the real world. EPS are performed in the real world. Then EPS are observable and measurable, and EPS are integrative. They are not isolated, they are integrative. So this is the nature of entrustable professional activity. One thing you have to remember, this whole session is an orientation. It's not a training. Because nobody will learn 100% in 1 hour or 1.5 hours. It has taken me 1.5 years to understand what is the meaning of EPA. And yesterday also I was sitting with one of the webinar, Understanding EPA. Today evening also on 7:30 I have another webinar by Amy. So tomorrow maybe the session would be a little more better. Okay. Now what is this EPA? EPA is something which is a very broad tent, a big tent of performance. Within that you have the competencies, 1, 2, 3 or whatever number. And within these competencies you have the specific learning objectives. You can see the relationship. When you see the outcomes, student is able to list the causes of something, the student is able to measure blood pressure. All these objectives together make up the competency, and these competencies together make up the EPA. So that is the kind of relationship. Now what is the checklist to say what is EPA? You ask some questions, and if you say yes or no, that will define whether it is EPA or not. First thing is it a part of essential professional work? MD, homeopathy, in whichever stream, is it essential for that person to be able to do this? Like we ask in SLOs, is it relevant? If it is yes, does it lead to recognized output of professional performance? Is it valid for the way it is spoken? Does it carry the validity of performance? Third, does it require adequate knowledge, skill and attitude? The combination of these, knowledge, skill and attitude. Not simply one knowledge is there, it cannot become a competency or EPA. Then does it reflect one or more competencies? A single competency is not EPA. There will be at least some shade of some other competency in the EPA. It's a multiple thing. Then is it observable and measurable? And finally, can it be executed within a time frame? We cannot drag on saying that, okay, this will go on because this competency has to develop over a period of 7-8 years. No, there is a time frame for it. So this is a checklist to pronounce something as an EPA or not an EPA. If we have to differentiate between competency and EPA, this is very important because we get into the kind of muddle of whether this is competency, this is EPA. There are 4 parameters on which basis you answer that, it becomes clear whether it is EPA or it is competency. One is performance. What is the performance? Second is what is the assessment. Third is what is the context. And fourth is what is the scope. Now the performance of competency is the readiness to task. Is this person ready to perform something? This person is capable. Measure blood pressure, he can do it. Perform some activity, she can do it. So can do, please mark word, can do. Can do is capability. The person has a readiness or capability to do, that is competency. Whereas in the EPA, the actual task execution, in the context, you say measuring the BP of an irritable patient. Any normal patient you can, irritable patient who is resisting. So that is an actual practice. Assessment is very interesting, is retrospective in competency. You conduct the assessment and say, okay, this person has done this, this person has done this. So this is the score. It is retrospective. The person has completed some activity and that we do the scoring. That is what is competency. In EPA, it is prospective. You have to predict this person will be able to do this. Quite risky. But that is what is EPA. Prospective. And the context is, it is context independent. We don't say that in this context is the person able to do, here is he able to do or she is able to do. Is he or she able to do this performance? Can this person do the intubation? Whether it is on the simulator, whether it is on the person, whether it is on the child, whether it is on the elderly individual, that don't say that. He is able to do intubation. When you look at the SLOs, you'll say the student will be able to perform this. It doesn't say in what context. Just do this. That is what is competency. Whereas in the EPA, it is embedded into the clinical context. You go further to say, to further define that in this context, in this context, in this context, you will be able to do. And the last one, the scope, is the knowledge, skill and attitudes of specific ability for this particular performance. Whereas for entrustable, it is integrated ability. All these come together. In competency, you can see even the isolation of knowledge, skill and attitude. But in the EPA, these cannot be isolated, these have to be integrated. So this is how you can differentiate between a competency and EPA. Now, as we implement the entrustable professional activities, I would ask you to recall the Dreyfus model of 5 levels of competence, and this is what we are mapping here. The novice, initially, the person can only do whatever you tell. You do this, and the person faithfully follows that and does it. In the second level, you have advanced beginner. In the advanced beginner, the person has acquired some kind of a capability, can predict, no, after this, this will have to be done. After this, this can be done. But still is uncertain. Is still under supervision to ask, this is what I feel, can it be done? Shall I do like this? Or is there a better way of doing it? So this is advanced beginner, the second level. The third level is competent. Competent is a person who can independently perform any capability. It is not in the context, without the context. And this is what is the training that we give for undergraduate learning. So when your postgraduates come, we have to have a kind of presumption that they already have the competency. Because your BHMS curriculum is competency based, you cannot start with 0 for PG. You have to start with 3, assuming that they have the 3. Then beyond the training, you have the proficient. Proficient is a person who can perform the competency with economization. If a competent person can complete an activity in half an hour, the proficient person can complete it in 10 minutes. The same activity, but only the time difference, economization. And the last one is called expert. Expert is a person who can apply what he or she has learned in one context in another context. You have learned something from physics. You are applying that physical laws into some clinical competency. So this is an expert. And this expert is where the deliberate professional practice happens. And when do you say you are able to entrust? That is the point of entrustment. Point of entrustment is when the training stops, the formal training, and the proficiency is achieved. See, this line keeps shifting. It is dynamic. When I make it, it will be touching this, and when I project it, it will be like this. So this is dynamic. Just a joke. Huh? So this is deliberate practice. And if you go further, this is where the entrustment happens. You allow the person. I'll show a little more of granularity here. At 0 level, novice, the person is not allowed to practice. Your first year BHMS person is not allowed to prescribe. Then the next level happens when the advanced beginner practice under direct supervision. The first level, you are training, you are demonstrating, and the student is performing it under your supervision, and you are there. So this is initially under, then is with, together. The third level, you have practice and on-demand supervision. The teacher may not be there completely kind of shadowing the person, but the teacher is there when the student performs alone. The student is given the independence. Okay, you take the case now. So in 3A, the student takes the case. The teacher goes and takes the case again. Has not given complete entrustment, is not there, because I don't know what this person will do. In the second level, 3B, the supervisor revisits key components. Doesn't take the whole case, But there are certain areas, in fact, when we come to assessment, and just make a mention of something called as key feature item, KFI, as one of the assessment tool. So this is what happens. What are the key areas which the student has to perform and where the students generally falter and make mistakes. Only those areas are identified, they are documented. The teacher looks at only those areas. And the next level is performed with distant supervision. The teacher is not there in the room, teacher is somewhere else, the supervisor is somewhere else. And if at all the student wants any help, he or she will call up, and the student and the teacher and the supervisor will give the support. Here is where the element of discernment, truthfulness, and vulnerability they come in. If the student does something, "Arey chalta hai, I have done something," even if it has gone wrong, you cannot trust that person because he is not truthful, he is not vulnerable. When you see the student asking, "Sir, this went wrong, what do I do? Madam, this went wrong, what should I do?" Then you are sure this person will not take things for granted, and that is where the foundation of entrustment begins. And beyond this, the person practices independently, you have the entrustment, and then the person is able to supervise others. This is how the incremental levels of freedom or lack of supervision they develop. And this is what is the background for entrustment. The only expectation I have out of this whole session is changing the mental model. Knowledge will come. Knowledge is available everywhere. What is most important is how do we respond? How do we adapt? How do we change? So that is what is most important. No, a kind of one example of how the entrustment is. At the zero level, you can say the person misleads, misrepresents, or purposely omits some information. And when the entrustment goes up, does not demonstrate deceit, doesn't show any kind of a deceptiveness, though may not understand what the information. So it still is something which, like you say, is advanced beginner. The next level is truthful, demonstrate sensitivity generally. The fourth level is a person is having trusted source of relevant, accurate information and conveys important factors. And finally, the complete entrustment is reliably truthful, accurate and appropriately detailed, demonstrate sensitivity in all but most difficult cases. So this is the kind of entrustment statements that develop incrementally. And this is how the whole syllabus has been designed with milestones. I'll come to that milestones now. So by the end of this session, if you are able to trace the evolution, if you are able to trace the evolution of competency as a theme, the historical evolution, if you are able to discuss the theoretical foundations of competency, if you can clarify the domains of competencies for homeopathic practice, the 6 levels, and explain the relevance of entrustable professional activities in homeopathic professional education, I think this session is useful. Now coming to the second component of it, how the structure of curriculum is. This, at the end of this session, you should be able to illustrate the structure of MD homeopathic curriculum, describe the salient features in MD homeopathic curriculum, identify the germane learning methods and the appropriate or authentic assessment methods for CBE. I'll be more focused on the last two in this. These two you already have seen the document, or this will be discussed. I'll only skim through this. So these are the subjects that you have for the part 1, part 2. Then these are the flow of curriculum. What you have is the title of the specialty course. Then you can see the whole thing which is there is represented, and the same thing is there in every document of every specialty. And these were the domains or the roles, domains of competencies that we have discussed. Now let me take a pause here and clarify There are some confusions about this word competency. I have gone through NMC curriculum also. There also there is a kind of confusion. What is competency? There are two things. One is, there are two expressions. One is domain of competency and second is performance competency. Domain of competency are those 6. These are the domains, are the roles. Performance competency is what the student is able to perform. The EPA, that is the performance competency. This is the domain competency. When we don't use any adjective and just say competency, that competency without the adjective is performance competency. It is not this domain. Otherwise, we specify domain of competency. Okay, with that in the background, this is how the EPS are listed. You can see the activities which are realistic in professional practice. More of this you will see in the post-lunch session. And this is how the EPS are mapped for the domains of competency. You can see if this is the EPA, it has these components and there is no component of this. And then you have the milestone. Milestone is when you have done EPA, if this is the EPA, it doesn't come just like that. A person doesn't acquire in the first instance, okay, I am now able to do that. There are some phases. And each of the phase has certain components. It builds. And that building of the competency is called the milestones. These are milestones for first semester, second, third, fourth, whatever. And whatever you see here, these are the levels. These are the levels. And here you can see no permission to act. You don't have 1 here because there are doctors. Then you have 2, permission to act under direct productive supervision. So this is 2. So that kind of mapping is done so that when you go through the curriculum document, you can relate to that. The next thing that you have is each of the paper is mapped for certain topics and these topics are coded. You have the number here and the code here. The reason is, one is for clarity, second is when we go for assessment. In the question paper, you might not see the whole topic, you might see this code. I'll come to that later. So this is how the flow is there. You can see here 9, there would be something like another 10 in the paper 1 of part 2 and another 10 of paper 2 of part 2. So that will be something like this 9. Then you have 10 to 11, 10 to 19, then 20 to 24. It is in a serial order. It is not like part 1 is 9, part 2 also has 9, 1, 2, 3, 4. It is a continuity of numbering which is there. Right. And then you have, this is important, this is the kind of template that you have for each of the topic. The topic has topic overview and these are the competencies. As I said, these are the performance competencies. This competency is given, what is the knowledge component of it, what is the skill component of it, and what is the reflection component of it. These are clearly stated. Then what is the learning method for it? We have not written deliberately teaching method. It is learning method because post-graduation is facilitating learning. So the appropriate learning methods are given. Then for assessment, what are the assessment methods? The prescribed text, they say there is a list of text which is given at some place. And finally, the domains of competency is knowledge and skill, patient care, homeopathic orientation, practice-based learning and improvement. So the whole topic has a kind of distillation of the entire activity there. The entire information is given in that. If you look into this table, you will get the complete picture of what is this whole activity or this competency. And for the assessment is now classified with, these are the different topics. Sometimes you may get the topic, sometimes you may get the code, and what is the marks allotted, what is the percentage. So total you get 100%. So you can have 10 marks from this, 10 from this, 10 from this, and from here you will have 30 marks. Here you have 20 marks, here you have 20 marks. So this is a possibility of mapping the curriculum with assessment blueprint. More of this you will discuss in the post-lunch session. Then you have the assessment. How do the assessment happen? I have taken the example of part 1. In part 1, you can say there are 3 subjects, 1, 2, 3, 4. There are 3 theory papers, and each of the 3 theory papers have paper minimum, 50 minimum they have to pass. And this is interesting. This is common bathroom for these 2. These 2 theory papers are fundamentals of homeopathy, whichever is a specialty, and the fundamentals of clinical medicine are fundamentals of homeopathy, whatever is the paper 2. They have a common practical or clinical paper and viva. Here you can see this is 100, 50 is a passing mark. Here you can see 200 is there, which is coming from 100 for viva, 100 for practical. So in that 100 of viva and 100 for practical, 20 each is for internal assessment. So effectively you have 80 for practical and 80 for clinical. 20 is already approved. And for this passing, this is interesting, the student has to score 80 plus 20. This is the differentiation maximum. In that, the student has to score 50% of this 160. Viva and practical put together, the student has to score 80, and the internal assessment, the student has to score 20. The reason why I am flagging this is, some time back we had the practice of the internal assessment, the viva, practical, everything getting clocked in, and finally we take 50%. So here, if in case the student had scored out of this 40, 35, he had to score only 65 to pass. But now he has to score 80. 65 will not pass. So in your regulations, in your university regulations, be clear that it is 50% of each component. 50% of viva practical and 50% of the internal assessment. So out of 40, the student has to get 20. Anyway, nobody gets below 20 unless there is some kind of, I will see you in the exam. Okay, but in the practical viva, suppose some mishap happens and you are not able to manage your external or something, whatever, let us not talk of those things. And if the student goes below 80, fail. Right? So I just wanted to flag this so that you are all clear about this. Then going further, we have this, the template for question paper. In the question paper, you have one problem based, which is for 20 marks, one question. Then there are long answer questions, short answer questions, 4 and 8. Together you have 100 marks. And this problem based learning has to be something like modified essay question, MEQ. When we come to the assessment, I will explain what is this MEQ. And this is how the question paper may look. One 20 mark question, 4 10 mark question, 8 5 mark questions. This is standardized. Then you have for the practical or clinical. For the practical or clinical, you have one internal assessment 20 is there. 80 marks are within the practical or clinical. So I have given 2A, 2B, 2C, so not to create any confusion. So 50 marks for the long case, 20 for short case. For the logbook or journal, whatever you say, it is 5 marks. And micro teaching, this is something which is introduced as a new thing in all the PG courses. We have this as a common feature in Rajiv Gandhi University. But across, the NCH has included this as a practice session of teaching in the practical exam or in the clinical exam. So there has to be one micro teaching. How to conduct that? I'll show you the checklist, but more of that we'll see later. And then coming to the viva, viva has anyway 20 internal assessment. Then the 80 marks are differentiated into the 4 components. Discussion of synopsis, this is part 1. If it is part 2, it will be discussion of dissertation. Then you have applied homeopathy, clinical understanding, laboratory or imaging investigations, each 20, 20, 20. How you distribute this internally is a kind of your institution or university. Now to implement this, you need to have an understanding of the whole system. There are some boards which are new, there are some components, concepts which are new, so you need to have a training for that. So one thing that is new is the learning context. Earlier for UG we were writing classroom based first, now it becomes clinic first, then you have community, then you have classroom. So these are the contexts in which the learning will happen. And then the learning methods have classified as individual and peer based. Individual learning methods could be self-regulated, reflective learning, portfolio based, library reference, e-learning, simulation, spaced repetition, deliberate practice, formative self-assessment. Then coming to the peer based methods, see, individual is when the person is learning on his or her own, individual. Peer-based is in the group. In the group, it could be problem-based, case-based, journal club, seminar, symposium, group discussion, project, workshop, brainstorming, bedside, ward rounds, outpatient-based, lab-based, community posting, role play, flipped learning, and jigsaw method. These are the different methods which are there. I'm not going to explain all these things. It will take 2 days. So you make a note of this. If there is any confusion, maybe we can have a discussion later, but these will be discussed, believe me, in the post-lunch session. Then coming to the assessment, just look at this image. What is the painting? This lady is there, and this person had to paint this lady, and this is painted. Why? That is what he sees. And that is what we see in the exam. We see what we know. And that is a mindset which has to change. We should see what is there, not what I want to see or what I have to see. So with this in the background, the assessment methods, there is something called as programmatic assessment. Just look at this image. Any clarity? What is the image here? No clarity. No, a little idea is there, little more idea, and this becomes clear. This is what is called programmatic assessment. Whatever you see here, these squares which go on becoming, the number becomes large, these are called as pixels here. And in our assessment, these are the data points. The more the number of data points, the more the clarity about the student's performance and predictability and entrustment. And how it happens is you have a longitudinal macro view and micro view in cognitive, affective, psychomotor domains. And it could be in any context of performance, assessment, or clinical. And what you see here is the data points which extend longitudinally. So when you take an overview of all these data points and combine them, that is where you can entrust, that you can have the entrustment of the person. So this is called as programmatic assessment, hallmark of competency-based education. And the assessment tools, there could be theory-based or performance-based. Theory-based purpose is for understanding the foundational knowledge, critical analysis of facts, synthesizing ideas, problem solving and decision making. And for performance-based, it is history taking, physical examination, diagnostic reasoning, clinical procedures, patient management, communication, and leadership, and more. So for this, now what are the tools? The tools for summative assessment could be problem-based learning, LAQ, SAQ, and the problem could be in the form of MEQ or SEQ. This is how it is there in the question paper. These are the tools which are there in the question paper, and these are the tools that you have to employ. And for the performance-based, you have the long case, you have the short case, you have micro teaching, and you have Viva. These are components which are there in the curriculum document. This is for summative. For the formative, in addition, you can have something like assignments, reflective rating, and portfolios for the theory-based learning. And for performance learning, you have a host of tools, checklist, rating scale, rubric, mini CX, DOPS, ASCII, PACS, SET, KFI, MSF. I'll just tell what this expansion is. No explanation. Mini CEX is mini clinical evaluation exercise. It is about any clinical assessment which is done as a kind of separate checklist or rating scale. DOPS is direct observation of procedural skills. These are the procedures like intubation or injection or something, whatever is done. These are the procedures. These do not come under CEX. CEX is only about the patient history taking and communication. Performance is performing some procedure, DOPS. Then you have OSCE, Objective Structured Clinical Examination, which is a structured assessment of the clinical competency. And PACS is the new model that we are now developing in Rajiv Gandhi University. It is called Programmatic Assessment of Clinical Competencies. We have started with the nursing faculty as a pilot here. Then you have SCT, which is the Script Concordance Test. KFI is Key Feature Item. MSF is Multi-Source Feedback. Multi-source feedback is something which is you take the feedback from various dimensions about the student from various sources, and finally you get an overview. I'll show you the checklist, rating scale, all these are available in the curriculum document. Those documents are already there. I'll just run through them. I'll not explain. This is for assessment of journal review. And in this context, let me say that journal club is the practicum for learning research methodology. Research methodology is a theoretical subject. How do you learn practicals is in the journal club. Then you have symposium. As you conduct symposium, what is the checklist? And this is for seminar. What are the checklist or areas that you have to rate? Then you have group discussion. When the group discussion is happening, what are the areas? Then you have clinical presentation. When the student is making clinical presentation, these are the areas to be seen. Then you have clinical work in the OPD or IPD, the checklist, rating cell in fact. And for teaching, skill practice, micro teaching, these are 15 areas to be seen. Then you have the continuation of the supervision of dissertation work, whether the student is doing this or not. And this is the portfolio or the journal. Then you have the templates. We say that the student has to attend seminar, workshop, conference. So what happens there? They go attend, then when they come back, what is the learning that they have? That they need to have some kind of a reflection. So this is the template. You can see that the students have to answer all these things. There'll be some seriousness. Then you have DOPS. There's a template for developing DOPS. You can take any procedure and develop. This is a template. Then mini CX. This is the template for developing mini CX. Okay. This is the structure of MD curriculum. Now how do we implement it? For implementing, there are certain things that need to be planned. There are two things majorly. One is outline the governance model for curriculum implementation, and second is plan for faculty development for CBDC. These are two areas. Very brief session. The first thing and foremost is to be compliant with the minimum standards of education. Whatever they say has to be there. Without that, further nothing will happen. And that is a basic. And this is what is the MSc. And you could say the concept of the entire academic governance is what is called as constructive alignment. The constructive alignment, you have the objectives or the outcomes, then you have the expected outcomes, you have the learning activities, and you have the assessment. These have to be completely integrated, aligned. That is the academic governance model. How do we align it? By various means. One is by training your students as the teachers, having an academic governance model in your institution, and education methodology. The academic governance model, as we already discussed in the UG, there has to be a curriculum coordination committee with the institutional head as the chief. Then you have the curriculum coordination committee. Under that, you have an integration with IQAC and METU, if at all IQAC is there in your institution. Then below that, there are some subcommittees and departmental committees. So these are the subcommittees: foundation, elective, assessment, early clinical exposure, alignment, integration, departmental. So these are the subcommittees. With that, the planning. This is for the 3 years of PG planning. Initially, you need to have the induction, maybe 7 days, that is what the thing says. Then about the clinical, there are 3 areas. Practice under direct supervision, maybe up to 12 months. You can have some control over. Then beyond, see, this is fading off here, and this is also fading, starting with this. Then practice on-demand supervision. Then practice independently. By the time they reach, they should be ready. Then there are some courseworks. One is about ethics, one is about BLS, which are already listed in the curriculum in the Gazette. So they have to be completed within the first term. Then you have the synopsis. Within 9 months, it has to be completed and approved. Once this is approved, the dissertation work starts. Then of course the group activities will start once the induction is over. UG teaching will be there in the last 1 year. So this is how some kind of a mapping of activities, a very rough, you may even call a crude model of it, you can refine it. Then for the education methodology, there are 3 areas. One is the basic course, then micro teaching practice sessions, and workshops for improving the host of skills. These are the requirements for implementing either UG or PG. And what are the contents? You have the objectives, about the outcomes. This is the teaching learning activities, and this is assessment, which are interconnected. And under each of these, there are certain components, like for the learning outcomes, these are the tools which have to be focused on. Then for the teaching learning activities, these are the areas of discussion. And for assessment, these are the areas of assessment. These are the areas of learning. Now going further, what is more important is developing a leadership model, because every teacher has to be, every student has to be a leader, and there's a model by learning, a model of a learning organization. So which says there are 5 components for any leadership: personal mastery, mental model, shared vision, team learning, and systems thinking. So this is a kind of template for training, learning, and with this in the background, what will happen is you will be able to prepare for curriculum implementation, the model of governance, and the faculty development. With this, what we have covered is the 3 areas: concept of entrustment, structure of curriculum, and preparing for implementation. So thank you all for this patient hearing. Thank you. Any question is there, we can see later.